Good morning, everyone. It's a interesting topic to start the day with, and let's see if I can do some ethical justice to the topic. So we'll start by some background about ethics in transplantation. Probably it's only field in GI surgery, but there's a lot of discussion about ethics, what is right, what is wrong, what is morality. I mean, no one discusses ethics while doing a Whipple surgery, but whenever it comes to liver transplantation, people just go on discussing more about ethics than the clinical aspects. And in the recent times, you must have noticed there are some publications in international journals and they have criticized the transplant community in India, and a very good rebuttal was also given by Dr. Rajesh from the Liver Transplant Society of India. It's exactly like the non-operating liver transplant surgeons are often take up ethical issues in India very energetically, and often foreign medical surgeons have an extraordinary interest in activity in India, and probably because India has become the transplant center of the world, probably the liver transplant center of the world. We do around 2,000, 3,000 liver transplants a year, second to US. So maybe the loss of business to them as surgery costs are much lower in India compared to US or Turkey or some places is a motivator. And often transplants are done in private sector in India and therefore often subject to criticism. And the cost of liver transplant has remained almost the same over the last 10, 20 years. The cost of every other aspect of life has inflated many times. So coming to the ethical dilemmas in LDLT, is there a benefit to the patient versus risk to the donor? We all know, is the donor under pressure, especially in Indian families, alcoholic male, single wife? Is the family pressurizing the wife to donate? Is the donor aware of risks? And the donor goes through a major operation which is not for his clinical benefit. It provides immense socioeconomic benefit to the donor, to the family, but not for his clinical benefit, and it's against the first principles of medicine. There are some things money can't buy. We know the tagline, and the benefits for the donor are social, psychological, which is of immense value to the donor. So I'll give an example. It's a large HCC, 63-year-old, retired CGHS beneficiary, chronic liver disease, underwent a TACE in 2022 in some center. There's no follow-up. Then comes to us in 2024 with ascites, sarcopenia, large HCC outside Milan, good biological behavior, no metastasis. This is the follow-up chart after a transplant, 1-year follow-up chart. If you go through it, it's more or less stable, no recurrence, on stable immunosuppression. I've taken permission from the son and the person before showing this picture. So the son happens to be a security analyst with a very reputed cyber firm. The person is a former income tax commissioner. They're well versed with internet. The son probably knows more of HCC than I do. And this is a 1-year post-transplant picture. So what motivated the son to donate? I mean, that was the ethical question for all of us. I mean, what they wanted the transplant. We as surgeons told it's beyond criteria, don't do it, it will have recurrence. But what motivated him to donate? Was it a guilt feeling? I could have said my relative, I want to do this for my father. Was there a hidden economic benefit to it? Was it love and affection? Or lack of awareness that the donor surgery is a massive procedure? Many, many people come to our OPD and tell, it's a chota surgery hai, ho jayega. It's not like that. So, I mean, there are multiple issues in LDLT, and the principle of double equipoise is so often spoken about. Like this cartoon, I mean, there is a train line, one line goes to kill 5 people, one line goes to kill 1 man. I mean, whom do you choose? And in deceased donor, there's a lot of issues on organ allocation with multiple stakeholders, the male score, child score, which HCCs to operate, which not to operate, timing of transplant, you can discuss endlessly. So many C patients, how do you decide? I mean, can we be moral but not ethical? Or can we be ethical but not moral? I mean, Steve Jobs had registered at multiple places because he could afford it and he could reach the transplant center within 1 hour. He was moral, but was it an ethical decision? Or I will not sign the donor card, I don't want to donate, but if I need the transplant, I will take the organ. I don't know. So, there is a bit of difference between morals and ethics. So morals are a set of personal guidelines, while ethics are probably the society-based rules which govern us. Another question that is often raised regarding ethics is whether transplant centers should be monitored. The rebuttal to it is most transplant centers will do easy cases, then they will refuse the difficult ones to keep their results good. Marginal donors, donors with steatosis, for those whom posterior sector grafts, low graft weights, they always generate a lot of controversy, lot of discussion, and whether we should give a donor to a sick patient or to a well-preserved recipient. And should a patient whose family refuses to donate be given an organ or not? So if you look at different types of ethics, we can all justify our decisions to any type of ethics. I mean, there's normative ethics, applied ethics like bioethics, which we are discussing right now, or meta-ethics. So, two basic principles are consequentialism, where an action is good, if the outcome we are intending is happy or good. Or the other opposite pole of it is where what people do, not the consequences of their action. So for that person whose picture I showed, I mean, if a team had decided not to operate because he was outside the criteria, whatever, they could have justified their action ethically. Or if a team had decided to operate, they could also have justified their action ethically. And as I told, there are different aspects of ethics, ethical decisions, and probably all our decisions can fit into any one of them, like emotivism, where moral statements are expression of emotions rather than objective truths. So, other issues which always confront us are, should transplant be allowed at all ages, whether there is an upper limit, should we transplant criminals who are lodged in jails, and what about a liver recipient being a kidney donor or vice versa, and organ swab donation, which means a kidney donor gives to a liver patient and a liver donor gives to the opposite patient. So it's basically exchanging livers and kidneys. Regarding the age of the donor, we all more or less agree that 18 years is the lower age limit, but is there an upper age limit? I mean, in our unit, often Dr. Gupta says that if he is fit for a hepatectomy, then why he is not fit for a donor hepatectomy? And to the elephant in the room, donor death, what happens when there is a donor death? Should the program close down? Or orphan grafts, when the recipient dies on table? If you are doing sick recipients, you have taken the donor, the liver is out, but the recipient dies. Orphan graft, who gets the donor? Who gets the graft? And mainly in countries like China, where they're taking organs from people on the death row, whether you should use such organs or not. Another common ethical dilemma that we face is in acute liver failure with a sick recipient. Will the patient improve on his own, or is it a futile transplant? How to decide, when to decide. And coming to another Pandora's box with unrelated donors, like how do you define a near relative? In India, most of the families are getting smaller and smaller. There is no one related available who is willing to donate. And friends probably are often more emotionally connected than the family members. And why cannot in-laws be considered as near relatives? Altruistic donors are popular in US, UK, but in India, the moment altruism comes in, everyone tells that it is not possible because of financial interests. And there are multiple issues in deceased donor liver transplants, like donation after cardiac arrest and all those issues. It's an entirely different ballgame in deceased donor liver transplant. And obviously, there has been quite a long discussion about organ allocation. It has been going on in different countries in different forms, whom to give, to the sickest or the best, and should it go to the most productive member of the society. This can go on ad infinitum. In India, like, organ allocation is a controversial issue in India till now. And in most states, it's like government hospital donation goes to government hospital donation. But what is the rationale when hardly any government hospital is doing liver transplants? And there's some government hospitals who charge money for it, some do not charge any money for it. I mean, so how do you decide? And whether the allocation should be made to patients or to hospitals. And can a hospital be a net receiver when it does not or cannot generate organs of their own? Alcohol is another thing, and the best quote I found on alcohol is only one single slide, is that this is made by a famous hepatologist from Spain. He tells that whether transplant evaluation should be done on alcohol-based hepatitis should be a medical assessment and not a moral or legal assessment. And I sort of agree with it, because who are we to judge people or patients? So whatever we do, the main ethical principles which guide us are those of utility, justice, and equity. And when we sit across the board and look at our patients, see them in the OPD, the only pole star that guides us is patient benefit and nothing else. Xenotransplantation is coming up, and it will open up another set of ethical issues to discuss in the future. And people now are more discussing about living after getting a life-saving transplant, long-term immunosuppression, consequences of immunosuppression. They are quite interesting issues that come up. I'd like to acknowledge Professor Mathur's contribution. He spent a lot of time discussing these topics, and I acknowledge everyone who has given suggestions for this topic. And I'll finish with this quote, is that the best interest of the patient is the only interest worth considering, and nothing else. That is the ethical guideline of liver transplant. Thank you.